My name is Kevin Tucker, and I'm going to be talking to you about toxic ingestions. I have no disclosures. So I'd like to start with the case presentation. The case is that of a 64-year-old man with a history of bipolar disorder and hypertension. He has normal renal function at baseline. He developed a gastrointestinal illness characterized by nausea, vomiting, and diarrhea. He subsequently became progressively confused with slurred speech and myoclonic jerks. His past medical history is notable for hypertension, bipolar disorder, and gout. His outpatient medications were lisinopril, 10 milligrams daily, allopurinol, 300 milligrams daily, and lithium carbonate, 300 milligrams 3 times daily. On physical examination, his temperature was 99 degrees Fahrenheit, his blood pressure was 90 over 58 millimeters of mercury, his heart rate was 79 and regular, his oxygen saturation was 100%. He had dry oral mucosa, his lungs were clear, he had a regular rate and rhythm, a normal S1 and S2, he had a soft and non-tender abdomen, he had no lower extremity edema. His examination was most significant for his mental status. He was agitated and disoriented. His laboratory data are as noted. His sodium was 146, his potassium was 4.2, chloride 110, bicarbonate 27, BUN 48, creatinine 3.2, calcium 8.7, phosphorus 6.1. His white blood cell count was 8.9 thousand. The hemoglobin was 14, the hematocrit was 42%, and the platelets were 218,000. The questions posed to us from the primary team were, are his signs and symptoms consistent with lithium toxicity? And is there a role for dialysis or other extracorporeal treatments in his management? So I'll use that case as a launching point to talk to you about poisonings and intoxications, starting with the scope of the problem. There were approximately 1,800 fatal exposures compiled by the American Association of Poison Control Centers in its 2015 annual report. 2,663 cases of exposures were treated with hemodialysis, and 49 cases were treated with hemoperfusion. The initial management of the poisoned or overdosed patients includes the basics, focusing on airway, breathing, and circulation. Other general therapies for patients with altered mental status may include hypertonic dextrose, thiamine, naloxone, and supplemental oxygen. There are several ways in which a drug or poison may be removed or eliminated. These include removal of the drug from the GI tract via gastric emptying or gastric lavage, enhancing its elimination through the GI tract via activated charcoal or cathartics, or enhancing its elimination through the kidneys via forced diuresis or manipulating the urinary pH. Finally, extracorporeal therapies, including hemodialysis and hemoperfusion, may be used for removing some drugs or toxins. In terms of manipulating the urinary pH, many toxic compounds are weak acids or bases. The ionization of such compounds is dependent upon the pK of the compound and the pH of the solution. As these substances pass through the kidney, they may be filtered, secreted, and reabsorbed. If the urinary pH is manipulated to favor the ionized form, the drug is trapped in luminal fluid and not reabsorbed. For this strategy to be effective, the renal excretion of the compound must be sufficient to make increased clearance a major route of elimination. Alkalinization can be achieved by administration of a bicarbonate-containing solution. The goal is to increase the urinary pH to 7 to 8. Carbonic anhydrase inhibitors should be avoided because of systemic metabolic acidosis. Drugs for which urinary alkalization may be effective include salicylates, phenobarbital, and chlorpropamide. The potential complications of alkalization include volume overload because of the sodium load, hypernatremia, ionized hypocalcemia, or hypokalemia due to bicarbonaturia, obligating potassium secretion. Forced diuresis is another way in which drugs may be eliminated through the kidneys. Increasing urinary flow rate by volume expansion with normal saline may be effective. This strategy is most beneficial for substances in which the GFR is an important determinant of excretion, and especially where the extracellular volume is contracted. And the classic example is lithium. Hemodialysis may be used for certain intoxications and poisonings. It's most beneficial for drugs that have very specific characteristics: a low volume of distribution, water soluble, low protein binding, and rapid equilibration between tissue and blood compartments. The dialysis procedure, you want to choose a dialyzer that has a high urea clearance, a high flux, depending upon the molecular weight of the substance to be removed. The bicarbonate concentration may need to be lowered if there's concurrent metabolic alkalosis. Phosphorus may need to be supplemented, particularly if repeated treatments are required. This is the table that lists some of the drugs and toxins that are very efficiently removed by hemodialysis. The toxic alcohols, including ethylene glycol, isopropanol, and methanol, are very efficiently removed by hemodialysis. Lithium and salicylate are also very easily removed by hemodialysis, and theophylline, to a certain extent, is also removed by hemodialysis. Another extracorporeal technique is hemoperfusion. It's a technique in which blood is passed through a cartridge packed with charcoal or carbon. Charcoal in the cartridge competes with plasma protein for the drug, absorbs it, and eliminates it from the circulation. It is more efficient at removing lipid-soluble drugs than is hemodialysis. Hemoperfusion requires more heparin than hemodialysis. The blood flow is typically 250 to 400 ml per minute, and some charcoal cartridges require priming with dextrose to load the cartridge. This is the table that shows some of the drugs and toxins that are efficiently removed by hemoperfusion. These include anticonvulsants and theophylline. And you can see that these drugs typically have a larger molecular weight than the drugs that are efficiently removed by hemodialysis. Interestingly, the number of cases receiving hemodialysis and hemoperfusion since the 1980s shows that the number of cases treated with hemodialysis has increased, while the number of cases treated with hemoperfusion has remained stable or declined. This graph shows trends for commonly accepted indications for hemodialysis and/or hemoperfusion. And you can see that the number of cases being treated with hemodialysis for lithium and ethylene glycol is increasing. Salicylates have had an upward trend, but the number of cases treated with charcoal hemoperfusion, these include drugs such as aminophylline and theophylline, has remained stable or declined. One of the reasons may be the availability of hemoperfusion. Charcoal hemoperfusion cartridges are available in only 1/3 of New York City hospitals receiving emergency patients. Only 3 in-hospital hemodialysis units in New York City had performed hemoperfusion within the preceding 5 years on 3 cases. We will now move into talking about specific drugs and toxins. We'll start with lithium. Lithium is a monovalent cation that is used to treat bipolar disorder. It has a very narrow therapeutic window. It's rapidly absorbed from the GI tract. Its levels peak at about 2 to 4 hours, and it has a volume of distribution of about 0.6 to 0.9 liters per kilogram. This drug is excreted by the kidney. Signs of lithium intoxication include a prolonged QT interval, nausea, vomiting, leukocytosis, and urine concentrating defects. The neurologic signs and symptoms of lithium intoxication are myriad. They include weakness, lightheadedness, a fine tremor, muscle twitching, drowsiness, hyperreflexia, slurred speech, tinnitus, confusion, clonus, muscular irritability, extrapyramidal symptoms, and finally, and ultimately, coma. Treatment options for lithium intoxication include saline diuresis. Sodium polystyrene sulfonate may be effective in certain cases. And finally, dialysis. The indications for hemodialysis and lithium intoxication include altered mental status, renal dysfunction, the inability to tolerate a sodium load, a level greater than 4 in acute toxicity, or a level greater than or equal to 2.5 in chronic toxicity. A second treatment may be required as the levels may rebound after the initial treatment. Next, we'll talk about the toxic alcohols. The 3 toxic alcohols most commonly associated with toxicologic emergencies are methanol, ethylene glycol, and isopropanol. Ethylene glycol is commonly used in antifreeze. It's also used in fire extinguishers, inks, pesticides, adhesives, air conditioning systems, and solar energy systems. Ethylene glycol is rapidly absorbed from the GI tract, and its levels peak within 1 to 4 hours. It's rapidly distributed throughout the body because of its high water solubility. It is metabolized by alcohol dehydrogenase to glycolaldehyde, glycolic acid, and oxalic acid, all of which are effectively removed by hemodialysis. The clinical findings in ethylene glycol intoxication include nausea and vomiting, lethargy, coma, nystagmus, ataxia, areflexia, myoclonic movements, seizures, an anion gap metabolic acidosis, an osmotal gap, oxalate crystals in the urine, hippurate crystals in the urine, hypocalcemia, and acute tubular necrosis. Crystalluria may persist for up to 40 hours with normal renal function. The crystals may take the form of dihydrate crystals, as illustrated here, or monohydrate crystals, which have this dumbbell shape. One may see only monohydrate crystals after about 7 hours. When the urine is examined under UV light with a Woods lamp, it may fluoresce. The fluorescence will be minimal or absent with a urine pH less than or equal to 4.5. Not all brands of antifreeze, however, have sodium fluorescein added, which causes the fluorescence. Methanol is another toxic alcohol that is effectively removed by hemodialysis. It's commonly found in windshield washing and de-icing solutions, carburetor cleaners, duplicating fluids, solid canned fuels, shellac, paint removers and thinners, and embalming fluids. Its levels peak within about 30 to 60 minutes. There's often a latent period of about 24 hours before the development of either toxic symptoms or metabolic acidosis. It has a volume of distribution of about 0.6 to 0.7 liters per kilogram. 75 to 85% is metabolized in the liver by alcohol dehydrogenase. 10 to 20% is excreted unchanged by the lungs. Alcohol dehydrogenase metabolizes methanol to formaldehyde. Formaldehyde is then oxidized to formic acid, which produces the metabolic acidosis and the retinal toxicity. The clinical findings in methanol intoxication include tachycardia, hypotension, seizures, coma, headache, somnolence, abdominal pain, nausea and vomiting, blurred vision, hyperemic optic discs, papilledema, blindness, and hemorrhagic and non-hemorrhagic necrosis of the putamen. This slide shows the metabolism of ethylene glycol. It's metabolized by alcohol dehydrogenase to produce glycolaldehyde and glycolic acid. The glycolic acid is then metabolized to either glycine, if pyridoxine is given, or thiamine. Thiamine may metabolize it to adipate. The glycolic acid is then metabolized to oxalate, The oxalate is the source of the major toxicity. This includes acute renal failure, crystalluria, hypocalcemia, and tissue deposition. The treatment of methanol and ethylene glycol intoxications includes, first, blocking alcohol dehydrogenase by administering either ethanol or fomepizole. Hemodialysis will correct both the metabolic abnormalities and remove the toxic metabolites. Thiamine and pyridoxine, as I showed you 2 slides ago, acts to shunt the metabolism away from toxic metabolites. Thiamine may be given as 100 milligrams every 6 hours to shunt the metabolism of glycosylic acid to alpha-hydroxy beta-ketoadipic acid. Pyridoxine, 50 milligrams q6 hours, may be given to shunt the metabolism from glycosylic acid to glycine. In methanol intoxication, folate may be given as an adjunct, and it enhances the elimination of formic acid. The indications for hemodialysis and ethylene glycol poisonings include severe metabolic acidosis, a pH of 7.25 to 7.3, unresponsive to therapy, renal failure, or ethylene glycol levels greater than 50 milligrams per deciliter, unless fomepizole is being administered concurrently and the patient is asymptomatic with a normal pH. The indications for dialysis and methanol poisoning include a methanol level greater than 50 milligrams per deciliter, visual, fundoscopic, or mental status changes, severe acidosis, serum formic acid levels that are elevated, or the consumption of the equivalent of more than 30 milliliters of pure methanol. Let's move on to talk about salicylates. Salicylates are the active ingredient in the common pain preparation aspirin. It may be found in combination with other drugs, for example, caffeine in some preparations. Salicylates stimulate the respiratory centers in the brain, leading to a respiratory alkalosis. They interfere with the Krebs cycle, limiting ATP production and producing a metabolic acidosis. The respiratory alkalosis predominates initially. However, by the time most adults reach the hospital, they have a combined respiratory alkalosis and metabolic acidosis. Patients who have a respiratory acidosis and metabolic acidosis are going to suffer the most severe consequences. They may develop salicylate-induced pulmonary edema. They may fatigue easily. CNS depression from a mixed overdose usually heralds a very poor prognosis. The clinical features of salicylate poisoning include an anion gap metabolic acidosis, respiratory alkalosis, tinnitus, deafness, vertigo, hallucinations, stupor, seizures, coma, nausea, vomiting, gastritis, pleurospasm, abnormal liver function tests, hypoglycemia, and hyperthermia. One can test for salicylates at the bedside by adding several drops of iron chloride to 1 milliliter of urine. The purple color indicates the presence of salicylic acid, acetoacetic acid, or phenylpyruvic acid. It is highly sensitive for small quantities of salicylic acid. Salicylic acid is a weak acid with a pKa of 3.5. It can thus be trapped in an alkaline environment. Alkalinization of the urine enhances its excretion. Alkalinization of the blood will keep it out of the CNS. Thus, alkalinization should be considered whenever the level is greater than 35 milligrams per deciliter. The goal urine pH is 7.5 to 8. The indications for hemodialysis and salicylate poisoning include renal failure, congestive heart failure, non-cardiogenic pulmonary edema, persistent CNS disturbances, progressive deterioration in vital signs, a severe acid-base or electrolyte disturbance, hepatic compromise with coagulopathy, or a salicylate level greater than 100 milligrams per deciliter. Now we're going to shift gears and talk about amphetamines and related drugs of abuse. Methamphetamine is a sympathomimetic amine that belongs to the class of phenylethylamines. Amphetamine was first synthesized in Germany in 1887. The plant-derived stimulant ephedra, containing the alkaloids ephedrine and pseudoephedrine, has been used in traditional Chinese medicine for more than 5,000 years to treat asthma and the common cold. A nasal decongestant containing amphetamine was marketed in 1932. Widespread abuse led the FDA to ban amphetamine inhalers in 1959. The passage of the Controlled Substances Act in 1970 reduced the rates of amphetamine abuse. The 1990s saw the explosion of so-called designer amphetamines. After cannabis, methamphetamine is the most widely used drug of abuse in the United States. About 5% of the U.S. population are estimated to have used meth, with about 300,000 new users each year. Clinically, it's used for the treatment of ADHD, narcolepsy, and short-term treatment of obesity. It can easily be synthesized in home labs from over-the-counter cold preparations. The effects of methamphetamine are myriad. It's taken up by cytoplasmic vesicles of presynaptic adrenergic neurons, thus displacing epinephrine, norepinephrine, dopamine, and serotonin. It may act on alpha and beta adrenergic receptors to produce hypertension, tachycardia, vasospasm, and hyperthermia. When it acts on dopamine receptors, it causes drug craving and psychiatric symptoms. With serotonergic stimulation, it may cause mood alterations and an abnormal response to hunger and thirst. The clinical features of meth intoxication include tachycardia, hyperthermia, agitation, psychosis, diaphoresis, and minimally reactive mydriasis. The clinical features of meth intoxication for which nephrology may be consulted include hypertension, in which case one should avoid beta blockers, which would lead to unopposed alpha stimulation, acute renal failure caused by rhabdomyolysis or renal hyperperfusion with ischemia. And finally, these patients may develop hyponatremia due to excess water intake and/or SIADH. Next, we'll talk about synthetic cannabinoids. These are commonly known as spice or K2. They're used recreationally but marketed as incense products, bath additives, or air fresheners. They're distributed in the form of dried leaves, a resin, or powder. It's typically a mixture of synthetic cannabinoids and an herbal additive. The mixture is typically smoked in a pipe or hookah, although inhalation and ingestion have also been described. Acute kidney injury has been associated with spice. This is the table outlining a series of cases of acute kidney injury due to synthetic cannabinoids. The pathologic features of kidney injury from spice are predominantly that of acute tubular necrosis, and you can see here that there's sloughing of the tubular epithelium as is consistent with acute tubular necrosis. So to summarize, drugs and poisons may be removed from the circulation via several methods. They may be removed from the GI tract via gastric emptying or charcoal adsorption. Enhanced renal elimination may be used with saline diuresis or alkalinization. Extracorporeal therapies such as hemodialysis and hemoperfusion are useful for certain drugs and intoxicants. And finally, for some drugs and intoxicants, there are specific antidotes such as fomepizole and ethanol, which block alcohol dehydrogenase in the case of the toxic alcohols. The serum concentrations of common poisons in excess of which hemodialysis or hemoperfusion should be considered is outlined in this table. You can see that for theophylline, a level greater than 40, hemoperfusion is preferred over hemodialysis. For phenobarbital, a level greater than 100, again, hemoperfusion is preferred over hemodialysis. For salicylates, a level greater than 1,000 milligrams per liter. Ethylene glycol, a level greater than 500 milligrams per liter. methanol, a level greater than 500 milligrams per liter. For lithium acutely, 4 milligrams per liter, and lithium chronically, 2.5 milligrams per liter. And you can see that for these last few, salicylates, ethylene glycol, methanol, and lithium, hemodialysis is the preferred extracorporeal treatment. The conventional wisdom regarding extracorporeal therapies for poisons and intoxications is somewhat obsolete in that it has been based upon obsolete technology. Furthermore, there have been very few clinical trials to examine the role of modern extracorporeal therapies in poisons and intoxications. Most dialyzers that are used in hospitals across the country are high flux and high efficiency dialyzers. These dialyzers have superior molecular cutoff and greater ultrafiltration coefficients than the older cuprophane dialyzers. Newer catheters achieve greater blood flow, also enhancing poison removal. Furthermore, in poisoning, protein binding sites become saturated. The proportion of free or dialyzable drug therefore increases. So even if the proportion of bound drug remains significant, it can dissociate rapidly from its binding sites, assuming it has a small binding constant. So returning to the case that I presented to you at the beginning of this talk, our patient had acute kidney injury in the setting of nausea, vomiting, diarrhea, coupled with ACE inhibitor use. His blood pressure was low, suggesting ongoing volume depletion. The follow-up is that his lithium level was 4.1 milligrams per liter. Intravenous normal saline was administered with restoration of the circulatory volume and rapid improvement in renal function. Dialysis was not required since lithium levels fall quickly as the GFR increases. Question 1. Hemodialysis is most effective at removing drugs and toxins with which of the following characteristics? A, highly protein bound. B, low volume of distribution. C, lipid soluble. D, slowly equilibrates between the blood and tissue compartments. The correct answer is B, a low volume of distribution. Hemodialysis is most effective at removing drugs that are water soluble and not protein bound. It is also most effective at removing drugs that rapidly equilibrate between the blood and tissue compartments. Therefore, the best answer is choice B. Question 2. Which of the following may be used to block the metabolism of ethylene glycol to toxic metabolites? A, ethanol. B, fomepizole. C, thiamine. D, pyridoxine. Or E, all of the above. The correct answer is E, all of the above. Ethanol and fomepizole both block alcohol dehydrogenase, thereby limiting the metabolism of ethylene glycol and the production of toxic metabolites. Thiamine and pyridoxine both shunt the metabolism of glycolic acid away from the production of oxalate. The best answer is therefore E. Question 3. Charcoal hemoperfusion would be more efficacious than hemodialysis in removal of which of the following drugs? A, lithium. B, ethylene glycol. C, theophylline. D, methanol. Or E, salicylate. The correct answer is C, theophylline. Theophylline is more highly protein-bound and lipid-soluble than each of the other compounds, which are very effectively removed by hemodialysis. Therefore, the best answer is C.